Okay, so as I mentioned, Artie and Nelly are not available. So if you don't know me, my name is Victoria Chernyak, so I'll be moderating for today. So again, I'm going to ask if anybody has any cases to share. You can either text me through chat or just speak up. And otherwise, I'll show some cases while everybody else gets.
I have one.
Okay, Arlene's going to go first. Are you sharing the screen?
Yeah, just one second.
Okay.
Can you enable the screen share?
Security, share screen. You got it.
Okay, all right, let's see. Okay. All right, so this is, can you see my screen now?
Yes, sir.
Can you see this scrolling here?
Yes.
Yes.
Okay, okay. So these are selected images from a young patient, pregnant female. So I'm scrolling through the axials here. These are sagittals. These are coronal sequences. History was pelvic pain and urinary retention. So any clues to the diagnosis? Any observations?
It's a retroverted uterus. And it's
Yes.
really compressing the urethra against the pubic bone. Almost
Yes.
like wedged in the pelvis. If you have ideas, text in the chat.
So the patient was in significant pain, so they put in the catheter, and this is an entity where this is a complication which can happen in pregnancy. So you're right that the most important thing is it's a very significantly retroverted uterus. So you can imagine that if this continues to grow and if it doesn't flip back, what can happen? So this entity is called, anybody, any diagnosis?
Fortunately, we're not OBGYNs, we're radiologists.
Incarceration of the
Yes,
retroverted uterus.
Absolutely right. Absolutely
Oh my
right. So
goodness.
let me screen share. Hold on 1 second. I can.
At least it's a name that makes sense. It's not some guy's name.
Yeah, let me screen share this. So this is a case of.
If you want to call it Pandy syndrome, that's fine.
I wish, but it's already been a described entity. So let me show you. Hold on 1 second.
That's crazy.
Give
So
you some
what do you have to do? They have to
pointers.
operate?
Let me see if I can correct screen. Let's see.
Are you able to share?
Yeah, I just want to share the correct screen. See if I can. Okay, can you see this? So yeah, this is a case of incarcerated uterus. So also known as trapped pregnant uterus. Approximately 15% of patients, they have a retropositioned uterus. Then over a period of time, majority actually, it kind of spontaneously moves up. And that's of course a good thing. But in minority of cases, approximately 1 in 3,000, you may have a uterine incarceration. So sometimes the clinical diagnosis is really vague. Means you have like lower pelvic pain, and the clue would be a retention or incontinence. Those are the important clues. You can also have like constipation, rectal pressure, tenesmus. So imaging is very characteristic. So imaging. So we have to kind of look at certain pointers and certain predisposing causes like pelvic masses, which can predispose to incarceration, adhesions can do that, and if there's any abnormal anatomy to the case, like variant uterine morphology or pelvic anatomy, which can predispose to that. So how to diagnose it? On ultrasound, it is important to notice the key thing is like if you're doing an ultrasound, you see like the bladder, and then you have a structure which is actually the elongated cervix, and then you see the uterus which is folded upon itself. The bladder can be variable; it may be distended or it may be collapsed. Depending on the presentation. This is an image from AJR. It's got a very nice article which talks about it. Of course, MRI will give you a much more of a global picture of uterine incarceration, and that was seen in our case as well. So in my thing, what I read about it, the best imaging clue for diagnosis is that you have to ask the question, where is the cervix? So if you can follow the cervix, then the diagnosis becomes very apparent. So you have here in this case like a compressed bladder, and then this is the elongated thing is the cervix, and then you can see that the uterus is folded upon itself. This is kind of also seen in that paper. They describe it very nicely, that the cervix may be just a thin sliver of thing, and it is you can see nicely demonstrated by this. So this was a case of uterine incarceration.
So,
all right.
So if it doesn't flip, do they have to operate?
Yes. So if it doesn't flip, it is almost like an emergency, and they have to operate, and that becomes like a complex thing. Many times there is for example, there's a fibroid or something. Then the risk of pregnancy loss also becomes higher. So the earlier they can intervene, the better it is. Of course, the patient will present with some symptoms, and you have to kind of frequently the radiology appearance would be the most diagnostic of all.
A request is coming. Can you show the first slide again, please?
The first slide, okay. This one.
Andrea, this is what you wanted to see?
This is actually very well described in the AJR article. The link is here. I'll paste it there. So if you really want to kind of read about it, it's a very nice article there.
Great. Awesome. Thank you. This was a really awesome case.
Sure.
Right. Does anybody else have any cases? Okay, so I'll start showing cases, and then just text me. Send the message if you have. Okay. So this was a case where the patient has kind of a mass, pancreatic mass, and then markedly dilated biliary tree, and so they send the patient for evaluation of the mass. Patient gets an MRI, and you notice that the duct is very, very dilated, the extrahepatic common duct, which is, kind of initially you start thinking that this is related to the mass. Then there's something odd about the way this is dilated. Any thoughts? Yeah, I'll scroll through the axials. So here's the dilatation.
You don't have any dilated ducts on the right, or hardly.
Right. So on the right, the ducts are not dilated. Right. And then if you look where the tumor is, it's more superior, and the duct, the common duct, is dilated way below that. So the tumor is not the cause of this dilatation. So then luckily we have a MAR from 2006, so like 14 years ago. And voila. The findings are very similar, maybe slightly worse now, but you know, over 14 years, not tremendously different. And of course there was no mass then. So thoughts? So now we have dilated left-sided intrahepatic bile duct and common hepatic duct, and nothing else is dilated.
Will this be a form of choledochal cyst?
Yes, which one?
Type 1.
Okay, so one is when it affects the intrahepatic biliary tree only. So this one is, it is a choledochal cyst, but it's type 4 because, right? So type 1 affects only the extrahepatic biliary tree, right? Type 2 is the diverticulum. Type 3 is a choledochal, and type 4 is both intrahepatic and extrahepatic biliary tree dilatation. Steve, am I right, or did I totally malfease?
So what explains lack of kind of dilatation on the right? Is it just a
So it's just,
variance?
right, so the right is not affected. So the choledochal cyst only affects the left and the extrahepatic duct. So it can affect only portions of the biliary tree. It doesn't have to affect the whole thing. Okay. The next one is kind of a this is a middle-aged woman, and you know, not an eye test. She has a kind of this infiltrative pancreatic mass. We see it nicely on pre-contrast. It's hypovascular, and you can kind of see it here. On T2, you will see a little bit of kind of duct radicals are dilated. There's a little bit of tethering of the adjacent stomach. So, thoughts? You can see restricted diffusion. Thoughts?
Not typical for adenocarcinoma.
Atypical?
Yeah.
How come? Oh no.
You get stuck. It's not really infiltrative, and doesn't look like it has it's not clear that it has a ductal origin.
Right.
Lymphoma?
Say again?
Lymphoma? Could this be a lymphoma?
Right. So lymphoma, some sort of unusual appearance of the ductal. That's what we thought. So the patient had surgery, and this is a met from colon cancer. Believe it or not. I've never seen this before.
Not from colon cancer.
That's a met from colon cancer.
Wow.
Path proven. Okay, so now it's just going to do this.
Victoria, we have a renal cell met that look just like this.
That's pretty cool.
Yeah.
Okay. So now the computer is going to do this funny.
Would IgG4 disease be in the differential?
Yeah, I mean, anything that's infiltrative. So even focal pancreatitis, I guess, theoretically, although lack of such severe parenchymal changes and lack of surrounding inflammation is unusual. Okay, let's hope that. So this is a young woman, again, not an eye test. Not even a diagnostic dilemma. It's more of a, I can't believe this is actually happening kind of thoughts?
With a gigantic bartholin cyst.
Right. So this is like the largest bartholin cyst I've ever seen in my life. And this it was the largest, I think it was 7 or 8 centimeters. 7 centimeters. and they sent her for to look at the any possible mass, and you can see how proteinaceous this thing is, and there were no solid components. There's just a this is just an unbelievable kind of the size, and there she's scheduled to get it excised, and I'm sure she's going to feel better when this is out. Okay, next case. So this is also kind of an unusual case. Patient had cirrhosis, and we see just tremendous number of liver lesions, right? And you can see that each individual liver lesion has what we call arterial phase hyperenhancement in the rim fashion, so rim arterial phase hyperenhancement. So when we see something like this, we're thinking of, if we're going to assign Laird's category, that would be Laird's M, which means that we're pretty confident this is malignant, but we're not confident this is HCC. So about 60% of LRMs are going to be non-HCC malignancy, about 37% are HCCs. So in this case, this was a path-proven intrahepatic cholangio, which is unusual to have it this extensive. But another unusual part of this case is that you can see that there are multiple splenic lesions, right? And when we go back, when we have this rim pattern enhancement, it goes into LRM category and it has to be biopsied. So it could have been just extensive HCC. It's still correct. So one thing, I guess one tidbit is that occasionally we see papers and they treat, like, if you have an LRM category and then path is HCC, as if it's a false diagnosis, but actually it's not. So LRM lesions may contain HCCs. We just don't want to. We want to make sure that whatever we call LR5 is very specific for HCC, but LRM is very specific for malignancy, but not necessarily HCC. But again, about 35 to 40% of LRMs are going to end up being HCCs.
Did they biopsy the splenic lesions?
No, we just assumed that they're tumors. And he had tumors, like he had lung mets, and it was just, the cancer was everywhere. But I've never seen a splenic met from cholangio. So this is my next case. Oh God, come on. Right. Okay, let me stop sharing again. Does anybody have another case? Because sometimes the computer needs a little break. Okay, GW, please. I don't think we can hear you.
Can you hear me?
Yes, now we can.
Okay, so I'll show an interesting case here. This is a elderly male coming in with abdominal pain.
Oof.
And then I will show you a chrono.
Just abdominal pain?
Just abdominal pain, and then I'll show you a sagittal, and then I'll show you some comparison images, because I know this is going a little bit fast. Okay.
Okay, so some suggestion came out. Oh, go ahead.
Okay, yeah. So let me show you some images and you guys can discuss. I'll show you the 4 years prior is on the left, current is on the right, and 4 years prior. I'm showing you the spleen here, there, and then I'm showing you 4 years prior at the presacral region.
Extramedullary hematopoiesis.
Okay, good. And any guesses on the cause, his diagnosis?
The bones are very dense.
That's right. So these are his bones, 4 years prior, and then current here. So there's, do you guys see for the bones?
Myelofibrosis, like that'll cause sclerosis in the bones and splenomegaly.
Yep. Yeah, so there, exactly. This is a case of primary myelofibrosis. He has osteosclerosis in his bones here. This is a sign of extramedullary hematopoiesis in the presacral region. This is also extramedullary hematopoiesis. And so let me show you some, this is from a paper here. So the presacral can be a weird site of extramedullary hematopoiesis. So primary myelofibrosis is like a disease where the bone marrow becomes fibrotic. And so that causes the
No
osteosclerosis.
new orchids running.
What? Yeah, and then, but it also at the same time, because the bone marrow is fibrotic, other areas of the body has to produce the marrow elements. So this is an example of the literature of myelofibrosis in the perirenal region, which is unusual. Most classically, you would see extramedullary hematopoiesis in the chest, in the posterior paraspinal area. And other weird spots of myelofibrosis would be omental infiltration. So in this one from the literature, this was biopsied and this was revealed to be extramedullary hematopoiesis. So what I learned from this case is unusual sites of extramedullary hematopoiesis.
Wow. Awesome case.
Okay.
Thank you. Anybody else? Okay, I'll try to share again. Okay, so this was a patient with kidney, and so you can see the native pancreas is very, very atrophic, native kidney is atrophic. So this is a combined renal pancreatic transplant. And you can see that, you know, in the right lower quadrant where the transplant, pancreatic transplant is, we just see one big moosh with some foci of air. Really couldn't say anything intelligent about it. And then patient had a follow-up CT a few days later. They gave contrast, and then you see this. They were concerned about the thrombosis of the splenic of the donor vein.
Like a pseudoaneurysm.
Like a pseudoaneurysm with a bleed.
Right.
Yeah.
So here's the coronal, right? And you can see this connects to the artery, and it's very, very uniform. And that's what we said, you know, it looks like a pseudoaneurysm with a bleed, and here's the corresponding angio. And you can see a little oozing there on the side. So they put a stent, and so far so good. Okay.
Victoria, in the setting of having been in the abdomen and how irregular it looks, would we be wrong if we call it a mycotic pseudoaneurysm? Was there any, or is that all just post-operative stranding in and around the vessels?
Right. No, I think that's a combination of stranding and somewhere in here is the pancreas. Although
Okay.
I don't necessarily know where. I don't know, these cases when they have to, when they require imaging, I find them to be very, very not like that. They don't do. They're not. They end up being very sick. Okay, hold on. Let me try to see if I can. Does anybody else have anything to share? Okay. Let me see if I can try to share again. Sorry. I think I killed my packs. Steve, do you have anything?
Oh, not really well prepared.
All right, here I think my packs decided to start working. So give me 1 second and let's see. Share screen. Okay. So this is a, maybe not. Try that again. Okay, so this patient had a tumor. You can see in 2018 she had this pancreatic mass. You can see that the duct is dilated. There's some calcifications and definite like soft tissue components. So also probably not a diagnostic dilemma, right? Thoughts? Okay, so, anybody? Steve?
Main IPMN?
Right, so IPMN probably, not probably, malignant, right? Because there's so much soft tissue component calcifications. So they took out, they did distal pancreatectomy in patient, had path proven malignant IPMN. And this is the pancreatic remnant, this is the head, neck, you can see how nice it looks. And this patient comes back 2 years later. And you can see what's happening to the remnant.
Oh man.
Right. So so yeah, I mean it's a dilemma, right? Because she's an older woman, she's in her late 70s, I think. So they didn't want to do the full pancreatectomy. But then if the duct is affected, you can have like dysplastic foci elsewhere. And then 2 years later, just progress into this crazy situation. So you can see here's a dilated duct, and then there's just these masses replacing the rest of the pancreas. It's pretty cool. If nobody has anything else, I'm going to start showing like cool Lyra's cases. You're just going to have to listen to me. Anybody? So the choices are continue with Lyra's cases or call it an early date. What would you guys prefer?
I
Will share one case.
Oh, good. Please. Anything but Lyra's cases, huh?
Yeah. Last week, Arti was showing us a percreta case.
Mm-hmm.
And this is one that I'd saved that was more flagrantly positive percreta.
Oh.
The one that she showed was like, maybe there wasn't any percreta, or a lot of them are like, they don't pan out. They think they see something sonographically, and then they, you do the MRI and it's like, maybe there's some abnormal placentation, but I'm not too sure if it's, percreta for sure. There's nothing to worry about. But this is, how bad they can get when it looks like percreta for real. And you see vessels actually, I think they did a cystoscopy here and could see the vascularity in the bladder wall on the same case. That's the abnormal placenta here with the internal bands and stuff like that. And then, you kind of lose the parts of the surface of the uterus down here. A lot of them are these low ones with the prior, if you can make it out, maybe an incision scar from a prior C-section. But here you can see all the vessels that are basically invading through the bladder wall. I think the coronal shows it as well.
That's pretty cool.
And what they normally do on these, in my experience, is they try to deliver this, and then sometimes IR is standing by to embolize this. There was one case where it was relatively early in pregnancy where they had to sacrifice the pregnancy on a case that was about this bad. But that was quite a few years ago when I think their approach to them was a little bit more, or a little less refined, let's say.
It's pretty cool. I mean, not for her, but. Anybody else? Okay, well, how about I show one very important Laird's case, because it underscores an important error or pitfall. Just give me 1 second. Okay, so this was a patient with cirrhosis, and he actually had personal HCC, which was resected. And, you know, so not only he has cirrhosis, but he has personal history of HCC, and then he has a lesion, which was followed. So this is April case. You can see that there's a lesion in segment 2, kind of enhances on late arterial phase, and, you know, arguably has washout appearance. Definitely is seen on T2. As you can see, mild T2 hyperintensity, which is an ancillary feature favoring malignancy. It had a little bit of restricted diffusion, and it was hypointense and hepatobiliary phase images. So at least at this point, it was also it also had some subthreshold growth from the study before. So, and this was kind of 1.2 centimeters. So at this point, it was appropriately called Laird's 5. So then patient, I believe, not I believe, I know, patient was a transplant candidate. So in these cases, sometimes they let the tumor grow to hit the T2 criteria so that the patient can get exception points. So that's what they were doing with this patient. So patient came back in August, and now you can see that the lesion really increased in size. So it went from 1.2 to 2.5 centimeter, you know, which can happen. But then on arterial phase, you can see that the enhancement now is in a rim pattern, right? So see that? Which is a new finding since before. So on the prior study, oh, God, this is so annoying.
And there were no treatments or interventions in between?
No treatments, no interventions. Patient was really followed because that's what happens to our patients. In the Bronx, we have fairly long, you know, waiting times. So, you know, so a lot of times they just follow the patient until it hits, without treatment, for the lesion to hit the T2 criteria to get exception points. So you can see before the enhancement was kind of uniform, but now it's clearly in the rim pattern. So the reason why I think this is an important case is because the radiologist who read the case appropriately recognized, and you can see kind of has a very funny appearance on the portal venous phase. In the periphery, there's some washout. So the radiologist who read the case described it correctly and say, you know, enhancement, arterial rim hyperenhancement, anterior phase hyperenhancement in a rim fashion. But because it was called Laird's 5 before, he again called it Laird's 5, and editorialized and said, this is maybe necrotic Leyer's 5 because of, quick growth or whatever. So the patient actually was, because, NOD's 2.5 centimeters, patient was being listed for transplant. So this came to me to fill out the tumor sheet. At this point, I said, wait a second. You can see that in addition to having rim arterial phase hyperenhancement, you can see that on hepatobiliary phase images, the tumor has targetoid appearance. You can see that the periphery is lower signal intensity, and the center is slightly higher, so that's another targetoid. So now we have two features of LRM. So we have arterial phase hyperenhancement in a rim fashion, so rim aphy, and targetoid appearance on hepatobiliary phase images. So at this point, regardless of what the tumor was called before, what the category was before, this has to be recategorized LRM. So at this point, I talked to the surgeons. I said, this cannot be called Leyer's 5. It has to be called LRM. It has to be biopsied prior to transplant listing. So even if it's an atypical HCC, this requires biopsy. So the patient actually underwent resection, and this, not surprisingly, came back as intrahepatic cholangio. So this is a very important kind of highlight why we have LRM as a category. Again, we want to preserve Leyer's 5 category to be as close to 100% specificity for HCC as possible. And then so that's just illustrates that. And we don't want to transplant patients with intrahepatic cholangio. They require different treatment. Another illustration is that small cholangios may mimic HCC. So this was this is a small, this is like a 1.2 centimeter cholangio. And at this point, there was really nothing that suggested LRM category. It was really truly LR5. Anyway, another interesting thing here is that you can see that there's kind of this halo of hypointensity surrounding the tumor on hepatobiliary phase images. And this halo of hypointensity is associated with increased chances of intravascular or microvascular invasion. And interestingly, this cholangio did have some microvascular invasion on path. So even though this is generally described with HCC, but this tumor really wants to be HCC, but it actually is not. All right.
Victoria, a few questions. So in your practice, how many times you would kind of reclassify the category based on such cases?
You mean how often I've seen this reclassification?
Yeah, means in your experience, how many times you would have probably done this kind of reclassification?
It's not common because HCCs obviously are far more common than cholangios and cirrhotics, but I have few cases. I have few cases where they start out very small and they go either LR3 or LR4, and then as they grow, they begin to manifest true targetoid features. I think I showed a case during this conference within the past year where the lesion started as by major features was LR4, but then had markedly restricted diffusion, and ended up being multiple cholangios as well. But as they grew, they developed targetoid features.
This was not a mixed type lesion. This was a pure cholangio.
This was pure cholangio.
The other thing was on the EOVist scan, that peripheral area of hypointensity, was it frank tumor infiltration or was it normal liver and some other changes on path?
So this halo is not the actual tumor infiltration. This halo is probably related to, tumor plugging the vessels regionally, and there's parenchymal kind of insult to that, but it's not the tumor that's infiltrating. But when you see something like this, it's consistently in the literature is associated with at least 3 times higher risk of microvascular invasion. So it's not definite that there will be microvascular invasion. So our surgeons ask that if we see it, you know, we reported something like, you know, halo, you know, hypo intense halo and hepatobiliary phase images, which is associated with increased risk of microvascular invasion. And then they figure out if they want to act on it or do something different. So it's not the actual tumor infiltration.
Okay, good. Good to know. Thanks.
Anybody else has anything interesting to share? Okay, so I guess we're gonna finish 15 minutes earlier. Thanks everybody for coming in. Oh, wait, stop. There's another case. Yay.
Yeah, this one's interesting. Now, let me just share this one here. So this is a young adult female, newly diagnosed with Crohn's disease a month ago. Had come into the ED with this CT. And on the CT, we can see some terminal ileal wall thickening, right? But nothing too impressive for a Crohn's patient. There's some cecal wall thickening, some ileocolic lymph nodes, and she was started on steroids and biologics. And 8 days later, got an MRE because her CRP was going higher. And so this is her MRE, and I want you guys to look at it and tell me what's going on.
Perforation.
Uh-huh. Yep, so a large amount of free air. And what's going on with the colon here?
Pneumatosis.
Yeah, pneumatosis. Yeah, pneumatosis.
Actually, I have almost exactly similar case, like just this weekend.
Oh, okay. And let me, so your patient was a Crohn's too?
Yes, is it? Yeah, and I can actually, I can quickly find, if you have time, we can review that as well.
Oh, okay. And let me just show you the post-con here. It's interesting. You can see the site of perforation of the cecum right about, okay, sorry. There's an area of hypoenhancement right in the posterior wall of the cecum right there. And so the interesting thing about this patient is a few weeks later, she also got another MRE, and she developed more sites of perforation here in the left colon and also in the right colon here. And to prove this, we did a CT with rectal contrast. And you can see abscesses here. But look at the contrast coming out of the colon here. And it forms a U and connects with the ascending colon perf, which is right here on the right side. So this is an unusual case of a patient with colonic perforation from Crohn's at 3 sites. I don't know if anybody's ever seen this before.
And this is just from inflammation or from treatment, or they don't even know?
We don't know, but we looked up the literature. High-dose steroids and biologics is reported in some patients. They're susceptible to perforation. And we think that's what happened to this patient.
What a case. Thank you.
Yep.
Okay. Anybody else? Okay, well, thank you everybody who brought cases. Thank you everybody who logged in. It was great to hear and see a lot of you. And we'll see you next week.
Yeah. Show that case next week.
Oh, wait, Kedar, do you want to show it now?
Well, I'm trying to search for it. I'll show it next week.
Okay, good. You have a homework then.
Yeah.
Ciao.
Thanks, Victoria. Hope you feel better.
Thanks.
Thank you all.
Bye.